The path to becoming a CRNA has officially shifted. As we enter 2026, the traditional wait and see approach to applications is no longer viable. The data shows a 22% increase in applicant volume over the last 24 months, meaning the standard resume is now the floor, not the ceiling. If you are an ICU nurse looking to pivot into anesthesia, you are no longer competing against a nurse in the pod next to you. You are competing against a global pool of high acuity clinicians who are optimizing their profiles 2 years in advance. In this blueprint, we are conducting a forensic audit of the entire journey, from the specific ICU units that admissions committees prioritize to the hidden academic markers that can salvage a low GPA. But before we touch the clinical requirements, we have to address the foundation gap, the silent reason most applications are rejected before they even reach an interview panel. We'll break that down in just a moment. The academic foundation audit. Most prospective nurse anesthetists focus on their cumulative GPA, but admissions committees are performing a much more surgical extraction. They are looking at your science GPA. Specifically, they are looking for a B or better in high-level sciences taken within the last 5 years. If your organic chemistry or physics grade is from a decade ago, or if you settled for a C during your sophomore year of nursing school, your application has a structural weakness. The data from the Council on Accreditation suggests that the average accepted student now carries a 3.5 to 3.8 science GPA. If you are below that threshold, you don't need to retake your entire degree. You need to target the power sciences. Taking a graduate level pathophysiology or pharmacology course now not only proves you can handle the doctoral workload, but it resets the committee's perception of your academic stamina. This is the first step in closing the gap. But academics are only 30% of the equation. The real gatekeeper is the unit you choose to work in, and as you'll see in our next audit, not all ICUs are created equal. The ICU acuity hierarchy. This is where most careers stall. Many nurses believe that any ICU experience counts. This is a myth that will cost you years of career progress. To become a nurse anesthetist, you must demonstrate mastery over high acuity, hemodynamically unstable patients. Admissions panels rank units. CVICU remains a gold standard because of the frequency of mechanical circulatory support, like ECMO, Impella, and IABP. If you are in an MICU or a neuro ICU, you aren't disqualified, but you must work twice as hard to prove you understand titration and invasive monitoring. If you're currently in the ER or a step-down unit, the clock hasn't started yet. You need to transition to a high-volume surgical or cardiac ICU immediately to begin your clinical time, accrual. But even in a CVICU, simply being there isn't enough. There is a specific skill checklist you must master before you even think about the CCRN, which we are diving into next. The $250,000 clinical checklist. If you want the income and autonomy of a nurse anesthetist, you have to prove you can handle the pressure of the operating room while you're still at the bedside. Admissions committees look for the high value for vasoactive drip titration, advanced ventilator management, invasive line management, specifically Swan-Ganz catheters, and experience with renal replacement therapy or ECMO. You should be the nurse who seeks out the crash patients. When a fresh heart comes out of surgery, you need to be the one primarying that patient. Documenting these experiences is critical. When you sit for your interview, you won't be asked general nursing questions. You will be asked about the physiology of the drugs you titrated and the waveforms on your monitor. This clinical depth is what separates a traveler from a future provider. Mastering these skills is the only way to survive the credentialing phase, which is where we calculate the true value of your certifications. The Credential Strength Audit. By year 2 of your ICU tenure, you must secure your CCRN. In 2026, the CCRN is no longer an extra achievement. It is a mandatory prerequisite for almost every top-tier program. It proves to the board that you have a national standard understanding of critical care. Beyond the CCRN, the GRE remains a point of contention. While some programs are phasing it out, many elite universities still use it as a filter for their doctoral candidates. If you choose to take it, aim for a combined score of 300 or higher. But there is a hidden credential that is often more powerful than a test score: shadowing hours. You need to log at least 16 to 40 hours with a practicing nurse anesthetist. This isn't just a box to check, it's where you verify that you actually want the job. If you haven't seen a difficult intubation or a rapid sequence induction in person, you aren't ready to apply. If this forensic breakdown is helping you map out your career, make sure to hit the subscribe button and turn on notifications. I am releasing a 10-video series dedicated strictly to the nurse anesthetist journey, and I don't want you to miss the next deep dive into application timing. Joining this community is the fastest way to stay updated on 2026 admissions trends. The 24-month eligibility calendar. Timing is the difference between a seamless transition and a wasted year. The eligibility window for a nurse anesthetist program usually opens once a year. If you miss the deadline by one day, you wait 365 days to try again. Your 24-month calendar should look like this. Months 1 through 12 are for unit immersion, mastering the skills we discussed earlier. Month 13 is when you sit for the CCRN. Months 14 through 18 are for GRE prep and shadowing. Months 19 through 22 are for the application push, securing your letters of recommendation and polishing your personal statement. This leaves you 2 months of interview prep before the first panels begin. If you try to compress this into 6 months, your burnout risk skyrockets and your application quality drops. But even with a perfect timeline, there is one document that causes more rejections than any other, and we're auditing that right now. The resume forensic cleanup. A nurse anesthetist resume should not look like a bedside nursing resume. A bedside resume focuses on tasks, checking vitals, passing meds, and patient satisfaction. A candidate's resume focuses on outcomes and acuity. Instead of saying managed patients on ventilators, you should say managed complex mechanical ventilation for ARDS patients, including prone positioning and recruitment maneuvers. Instead of titrated drips, say managed titrations of multiple vasoactive infusions, including norepinephrine, vasopressin, and Presidex in unstable shock states. You must speak the language of the provider before you are given the title. This forensic shift in your language tells the committee that you have already transitioned your mindset from a task doer to a critical thinker. This leads us to the highest pressure moment of the entire journey, the interview. The clinical interview gauntlet. The interview for a nurse anesthetist program is unlike any job interview you've ever had. It is a clinical gauntlet. You will likely be given a patient scenario. Your patient is post-op day 1 from a CABG. Their blood pressure is dropping, their CVP is rising, and their heart rate is tachycardic. What do? They aren't just looking for the right answer, though you better have it. They are looking at how you handle the stress response. Do you crumble when they ask why 4 times in a row? Do you admit when you don't know an answer, or do you try to fake it? Faking it in an interview is an immediate disqualification because faking it in the OR kills patients. You must be able to explain the why behind every action. If you give a drug, you must know its mechanism of action, its half-life, and its contraindications. This is where your 24 months of preparation either pays off or falls apart. The Dynasty Mindset Summary. Becoming a nurse anesthetist is a marathon of precision. It is about moving from the traveler illusion of short-term cash to the dynasty path of long-term autonomy and wealth. We have audited the academics, ranked the units, and mapped the timeline. The only variable left is your execution. The path is difficult by design. It filters for those who are obsessed with excellence. If you follow this 2026 blueprint, you aren't just applying to a school, you are auditing your future self to ensure you are the most prepared candidate in the room. You have the map, you have the data, and now you have the strategy. The journey doesn't end here. To see the forensic data on how the nurse anesthetist income stacks up against the travel nursing glass ceiling, click the video on your screen right now. I'll see you in the next audit.